Now we can see it. Thank you so much.
I'll go back. Okay. So I was just talking about the anatomy of cerebral circulation. This is the internal carotid arteries, which is bifurcating into MCA, middle cerebral artery, and the anterior cerebral artery, and on either side. And there's a communication between the on either side of the cerebral hemisphere by the anterior communicating artery. From the posterior circulation, we have the basilar artery, which bifurcates into posterior cerebral arteries. And there's communication between the anterior circulation and the posterior circulation with the posterior communicating artery between ICA and the PCA. This is a representation of the distribution of the territories by the various arteries. This is the anterior cerebral artery, and this is the middle cerebral artery, and this is a posterior cerebral artery. Now, it is important to know the homunculus at this point of time, because whenever there's the anterior cerebral artery is affected, or there's a stroke or middle cerebral artery, the anterior cerebral artery supplies at this foot and the lower limbs. So whenever there is a stroke here, we get the weakness of the lower limbs, and with the MCA territory stroke, we get a stroke or the weakness of the upper limb on the opposite side. The vertebrobasilar system is from two vertebral arteries joined to form the basilar artery, and that bifurcates into posterior cerebral arteries, and the cerebellum and the brainstem is supplied by the superior cerebral arteries on the pontine and other inferior cerebral arteries. The venous drainage is from the superior sagittal sinus and the inferior sagittal sinus and the straight sinus. We have all this drain into the what we call the storcula, and from here it forms the sigmoid sinus, and so transverse sinus, the sigmoid sinus, and then continues as the internal jugular vein. This is the point at which there is no contamination from the extracerebral veins, venous drainage. So at this point where the jugular bulb is, this is the point where we always leave our jugular catheters for monitoring jugular venous oxygen saturation, which is represent the global cerebral oxygenation. We know that it's though it just weighs about 2% of the body weight, there's a 15% of the cardiac output comes to the brain because of the increased activity. It has got a high metabolic activity and oxygen consumption, and to maintain the the reticular activating system, synthesis and storage of neurotransmitters, this increase in the cardiac output and oxygen consumption is essential. Now, oxygen requirement for in the brain is global cerebral oxygen requirement is 3.5 to 4.5 ml per 100 grams per minute, and glucose seems to be only substrate for its energy production, and about 60% of the energy production is for the maintenance synaptic transmission, that's about 3.3 ml, and to maintain the integrity of the cell is about 2.2 ml. There's 40% is for the maintenance of the integrity. Now, pharmacological suppression can happen only up to synaptic transmission, about 60% of suppression. However, if you want a further suppression here, it is a hypothermia what we normally induce. What we normally see in post cardiac arrest hypothermia is basically to protect the brain, not just about the transmission, but also the cellular protection. Now, CMROTs can be calculated. It's basically estimation is done using the MRI technique, and I don't go into the details. What is important is there are various systems which maintains the CMRO2, and any of these the flow metabolism coupling and the supply of the substrate will always continues depending on the blood flow. Now, there are various factors which can increase the CMRO2, that is in increased temperature or the seizures. Patients with seizures will normally see that status epilepticus, or patients with other seizures, they can have increase in the oxygen demand and the glucose requirement. So this is a time when there is CMRO2 significantly increases. However, when the temperature increases beyond a particular point of 40 degrees centigrade, there is cellular mitochondrial dysfunction and cellular dysfunction and death. So beyond a particular range of 40 degrees centigrade, the brain fails to maintain the adequate cerebral oxygen requirement or metabolism. The same effect is seen with cerebral blood flow. Cerebral blood flow inhalation agents Inhalation agents basically reduces cerebral metabolic rate of oxygen and thereby suppress because of suppression of the metabolism. However, it is offset within 1 Mach. There is cerebral blood flow and oxygen flow coupling is happening, and when there is beyond 2 Mach or 1.5 to 2 Mach values, there is substantial increase in cerebral flow, which is offset by this increased vasodilation and cerebral blood flow, even though there is a decrease in the CMRO2, which I'll come to it later again. And coming to the cerebral blood flow, that's about metabolism. And because of its high activity, there is always a need for increase in the flow whenever there is an increase in the requirement of substrates. The normal cerebral blood flow is about 45 to 55 ml per 100 grams per minute. And we also know that there is brain completely dependent on the flow for its substrate delivery because it does not have much reserve in the form of glucose storage. So the glucose supply has to be continuous whenever there is a need for increase metabolism or increase if there's any activity. This constant flow is there's a need for the constant flow to be to happen, which is brought about by pressure autoregulation of flow metabolism coupling, which is a complex mechanism. However, I'll just not go through in detail because even after 20 years or 3 decades, I have been reading the same thing again and again, but not much changes have happened. However, people have gone into the molecular level at the receptor and ionic transport level. However, there's not much breakthrough has happened, but still all has been postulated based on your laboratory studies. Now, when we call what is autoregulation, that has been nicely explained by other day by Dr. Murali. It is the mechanism by which the organ maintains its cerebral blood flow or maintains its flow across varying pressures, with the limit pressures of about 60 to 150 millimeters of mercury of cerebral perfusion pressures. The flow continues to be the same. There's no much change in the flow. However, when the pressure increases, the flow remains constant. Even when the pressure decreases, again the flow remains constant. That is within the normal range or within the range of 50 to 150 millimeters of mercury of cerebral perfusion pressures. When the pressure drops beyond that there is passive drop in the flow. When the pressure goes beyond the limit of photoregulatory range, then probably there is a passive increase in the cerebral blood flow. We'll come to it how this mechanism is brought about. Various factors has been involved and then has been explained. The most important is a myogenic or pressure autoregulation. It's been told that it's basically response to the arterial pressure changes and also the response to the pulsatile pressure. Now, pulsatile pressure is what is most important, and that is one of the reasons why when you go on cardiopulmonary bypass, they try to maintain the pulsatile pressure because they have seen that when the pulsatile pressure is maintained, the autoregulation is still maintained and there is adequate flow without much effect on the ischemic issues with the brain during the cardiopulmonary bypass. Various mediators, this is brought about with various mediators like calcium, hydrogen, adenosine. The most important being nitric oxide. Other metabolic and chemical influences also play a role in this regulation of flow whenever there is need for increased demand. How is it brought about? What happens actually the vessel in the vasculature? When there is at this point, when there is increase in the blood pressure, there is an increase in the resistance. This is brought about increase in the resistance at the arterial level, and there is a narrowing of this the vessels or the arterioles, and there is increased resistance. As the resistance increases, the flow reduces. So as the pressure increases, the caliber of the vessel reduces and the resistance increases, and thereby the flow reduces. Beyond the autoregulatory range, there is passive dilation and there is no more regulation of the flow. Whereas as the pressure drops, as the pressure comes down towards the 50 millimeters of mercury, there is a passive vasodilation of the vessels. So as there is vasodilation, there is decreased resistance. When the resistance decreases, the flow improves. So this is how the mechanism is brought about by the smooth muscle, which is almost instantaneous, and this is how the flow is maintained within the range of 50 to 150 millimeters of mercury. Now, beyond the autoregulatory range, there is no further increase vasodilation, this becomes more passive. As the pressure drops, it continues to drop and the cerebral blood flow significantly reduces, resulting in cerebral damage. And if you can see here, as the blood pressure falls, the ICP increases because of ischemia. As there is improvement in the, as the pressure improves, there is protection and there is decrease in the ICP. However, if there is loss of autoregulation, this becomes completely pressure passive. As the pressure increases, there is increase in the flow because of there is loss of autoregulation, and ICP increases because of increase in cerebral blood volume in the intracranial compartment. And as the blood pressure drops, there is a drop in the flow and there is the change in the ICP. Just to show the relationship between the cerebral blood flow, cerebral vascular resistance, and the arterial diameter. Now, if you look at, this is the cerebral blood flow. As the pressure, and this is on the x-axis, you see cerebral perfusion pressures. As the pressure increases, you can see the arterial diameter start increasing and start reducing. The small becomes more and more smaller. There is increase in the resistance. So this tries to maintain the cerebral blood flow constant. And the same thing happens beyond the autoregulated range. There's no further reduction or small the constriction of the vessels, and it becomes completely pressure passive, and there is what we call as breakthrough range. In the ischemic range, we come here, we have the the pressure reduces, the dilatation is maximal at this point, and there's no further reduction in the CVR, and thus in the ischemic range it becomes passive. As the pressure drops, there's a further drop in the flow and causes and ischemia. Now, what happens beyond that particular in the ischemic range? Now, about various effects is hemodynamic compensation and synaptic inhibition and synaptic failure. As the pressure drops, severe vascular resistance cannot further drop. So there is a constant vascular resistance. Cerebral blood volume becomes constant. What happens is there is increase in the oxygen extraction, and after that there is no further change in oxygen extraction because there is no further flow. Later on, when it becomes ischemic range, the CMRO2 drops and there is ionic shift, and at which this causes cell failure. Looking at the normal pressure relationship with resistance, as there is a drop in the pressures, there's a drop in the resistance, and the flow drops. But as the autoregulation comes into play, the resistance continues to stay lower, and as long as the pressure is there, and then as the pressure is brought back to normal, you can see here, as the pressure continues to be low, still the flow has been restored to normal because of autoregulation coming into play. And once the pressure is restored to normal, there is a slight increase in the flow as the flow before the autoregulation comes into play, and then the flow comes back to normal. Whereas in vasoparalyzed, the pressure drops, there is no change in the resistance, is maximally vasodilated, vasoconstricted, and the flow continues to be low as long as the pressure is low. There are certain tests of autoregulation. I'll not go into details of it. What is important here is when we do the transcranial Doppler flow velocities, which is the indirect estimate of the cerebral blood flow, when the flow velocities comes back to normal within 5 seconds, that means the autoregulation is intact. If it is 5 to 15 seconds, 5 to 10 seconds, and more than 5 to 10 seconds, it is impaired. Whereas if it's more than 15 seconds, that means it's lost. This is exactly what happens when during volatile anesthetic agents. In the low dose, we can see that there is a shift of the curve, and cerebral blood flow initially increases, and there is as the autoregulation is slightly impaired, it takes a longer time. With moderate dose and high doses, autoregulation is lost. So at this point of time, with high doses of more than 2 max, there is no relationship with respect to the blood pressure and the flow. So it becomes pressure passive. And this is very important, because when we use a high dose of inhalation agent, if there is a drop in the blood pressure, there is a passive drop in the flow, and they can induce cerebral ischemia. This becomes more important when there is patients is already having a cerebral insult. This just to show how the blood pressure, the responses to blood pressure with various anesthetics. You have, this is an awake state, it comes back, you can see the blood pressure drops and takes a little bit time to come back to normal. And as the pressure drops in cerebral blood flow velocity just comes down, immediately it comes back to baseline. With isoflurane, you can see because of the loss of autoregulation, it takes a much longer time to come back to baseline compared to remifentanil propofol anesthesia. The next is flow metabolism coupling. There is various factors involved in maintenance of the flow for increase in the metabolism, and this basically happens whenever there is an increase in the metabolism. There is the increase in the flow, which is nicely coupled because of various potent vasodilators and various hydrogen ions and endothelin, which are vasodilators. Now, this cannot be explained because it's causing the flow metabolism coupling. This is how the fMRI looks like. Whenever there is a stimulus or the hand or movement of the hand, there is increase in the contralateral side of the area, which is represented by the hand. And this is the ipsilateral hemisphere for comparison. So this is how the flow metabolism coupling has been estimated in the cortical activity, and the flow metabolism coupling is estimated in normal subjects or in pathological states. There is extensive neurogenic control by both sympathetic and parasympathetic. However, their role in control of cerebral blood flow in various disease states has not been clearly defined. So I'll not go into that. Most of the studies has been done in animals. Many factors has been used. Even the stellate ganglion block, which has been used in human subjects, has not made much changes with respect to cerebral blood flow and autoregulation, even when these are denervated. However, patient having a higher sympathetic tone, there is the move and the shift of the autoregulatory curve to the right. This we see in hypertensive patients. They have a higher sympathetic tone. And what is the importance of this is the hypertensive patients tolerate hypotension poorly compared to the patients normal pressure patients. Now, this because this is shift to the right. This is no more at 50 millimeters of mercury. This is about 70 to 80 millimeters of mercury. So which means that whenever there is a drop in the blood pressures, it cannot further any drop beyond 60 to 70 millimeters of mercury. There is a passive drop in the flow. So in a higher sympathetic tone, the pressures they tolerate poorly the hypotension. Now, one should remember that vascular reactivity to carbon dioxide is not the same as the autoregulation, pressure autoregulation. This is purely how the carbon dioxide acts or reacts for the response for increase in the carbon dioxide or decrease in the carbon dioxide. Now, various modulators and the like nitric oxide and GMP pathways has been explained, and this purely moderate the cerebral vascular resistance, and this actually happens only between 20 and 80 millimeters of mercury. And this is one of the robust. It is the last to be affected even in severe head injury patients or severe neurological disease. If this is lost, which means that the patient has a very poor outcome. And how is it brought about? Let's see the 20 millimeters mercury. As the pressure, as the CO2 levels increases, there is vasodilation and there is increase in the cerebral blood flow and cerebral blood volume, and thus there is a rise in the PSA and in the ICP. So this hypoventilation can cause a significant increase in the PaCO2 values. That is one of the reasons why patients who comes preoperatively for any neurosurgical disease, we do not give any sedatives or pre-medication, because if they hypoventilate, they're already on the compromised state, they can cause vasodilation, cause increase in the ICP. There's the importance of that, why we do not give any sedation and avoid any hyperventilation in these patients. Now, when you come down towards hyperventilation or inducing hypocapnia, beyond 40 millimeters, less than 40 millimeters mercury, up to 20 millimeters of mercury, it causes vasoconstriction and causes reduction in the cerebral blood flow. Now, earlier it was thought that hyperventilation is very advantageous for patients with head injury or patients with neurological disease or raised ICP. However, because in these pathological states that already affect the cerebral blood flow is already affected, and there is increase in the edema and reduction of reduction of blood flow because of hypocapnia or vasoconstriction can further cause ischemia. So this is one of the reasons why the trend is towards the maintenance of normocapnia or mild hypocapnia up to 34 to 36 millimeters of mercury of PaCO2 values, which ensures that there is no further ischemic episodes in these patients. So we do not hyperventilate in any of the neurosurgical patients unless there is a clear indication for that to be done, whereas in acute rise in the ICP and with the monitoring of cerebral oxygenation. And its effect on hypotension and on blood pressures and PaCO2, when there is severe hypotension, there is already maximum vasodilation, though PaCO2 values does not have any effect on the vasculature in these situations. Reactivity can be measured using the change in the cerebral blood flow and PaCO2 values. What is been shown is for every millimeters increase, percent increase in the PaCO2, there's every millimeter there's increase up to 3 to 4% increase in the cerebral blood flow. As I mentioned, if the CO2 response is deranged, the patient has got a very poor prognosis because that's one of the robust and is last affected. Oxygen has very minimal effect on the cerebral blood flow mechanism. However, when there is low cerebral blood, low PO2 values, this causes vasodilation basically because of acidosis and various factors involved for increasing the flow. Now, effect of temperature, which I already told, there is increase in temperature, there is increase in the activity and increase in cerebral metabolic activity and the flow. But when a decrease in temperature, there is definite decrease in the synaptic transmission and further decrease in the cell function, cell activity, which can further reduce to up to 10% or 0%, depending on, this is being defined as Q10, whereas the difference of 10 degrees, the change in cerebral metabolic rate from the baseline to at the end of the 27 degrees, the ratio is taken, and the 2.4, that is at 37 degrees to 27 degrees, the change in 2.4 means that there is 2.4 times the reduction in cerebral metabolic rate. And further reduction can be seen from 27 to 17 degrees. We see about 5 that means 5 times reduction in the cerebral metabolic rate for oxygen. So looking at it, which is myogenic or neurogenic or metabolic and endothelial factors which control the cerebral perfusion, cerebral blood flow in spite of varying change in the cerebral perfusion pressures. Just to note on pediatric, it is much higher in the pediatric age group of cerebral blood flow and CMRO2. It is understandable because there is increase in the development and increase in the activity. Autoregulation in neonates has been explained about in the older children is about 40 to 90 millimeters mercury, and the carbon dioxide reactivity is not seen in newborns and neonates. However, as the child grows older in infants, it comes back to the adult responses. I just want to show how the inhalation agents affects the cerebral blood flow. All inhalation agents does not act at the same site and does not have a same effect. If you look at the halothane and isoflurane, halothane increases much higher cerebral blood flow compared to isoflurane because it causes more vasodilation and more increase in the flow compared to isoflurane. This, I think, most of you are familiar, and this is the one table which says about most of the inhalation agents causes increase in the cerebral blood flow because of its effect on the cerebral vasodilation and reduces the CMRO2. Based on the degree of reduction in CMRO2, the effect is seen on the ICP. Now, autoregulation is impaired or lost only beyond 2 MAC values, and otherwise is not affected much at normal clinical usage of 1 to 1.2 max. Similarly, except for ketamine, all the other intravenous agents causes reduction in cerebral blood flow because of causes vasoconstriction, and CMRO2 reduction directly affects the cerebral metabolic activity is reduced. There's not much effect on the autoregulation. Midazolam in normal doses does not cause, in the higher doses it causes change in the autoregulation. In hypertensive patients, I've already mentioned about that. What is important to know here is if the blood pressure is controlled and the restores to normal, and the curve which was shifted to the right is shifted back to normal range. And that is the importance of controlling hypertension in patients with neurological disease, which patient with having hypertension. The cerebral blood flow on CMRO2 reduces with age, probably because of the cortex starts shrinking, and with aging, and carbon dioxide reactivity reduces with age, probably because of reduced responses of these vasculature. Measurement of cerebral blood flow, basically we have various invasive techniques and the non-invasive techniques. Basically, the TCD is one which is a bedside non-invasive technique which is routinely used, though it doesn't give the absolute values of cerebral blood flow. It gives the flow velocities, and velocities has been translated into blood flow. And NIRS tells you about the cerebral oximetry, and this is mainly used in following carotid endarterectomy, or during carotid endarterectomy, or following during aneurysm surgery, or in various other neurological issue pathology, which tells us that the improvement in the saturation once tells us about improvement in the flow, and thus the reduction in the ischemia. SjO2 usually monitor the jugular bulb insertion. I told you about that. And any reduction, what is important is it tells us about the global cerebral blood flow and does not tell you about the regional flow, which is most important for us. And what we need to know is the knee ischemic is closely correlates with oxygen with ischemia. If there is a reduction in the SjO2 values of less than 50%, there is a definite ischemia seen in these patients. And if the normal is 65 to 75%, anything less than 50% taken as the significant definite ischemia. Anything less than 65 has an impending, and still the patients can be improved, and the saturation and if the flow is improved, probably the saturation also improves. If the patient has a persistent increase in the SjO2, which means it only suggests there's hyperemia, which may be detrimental in certain group of patients, and this can be managed based on the values of SjO2. On the certain pathological situations where we definitely know that there is a significant reduction in CMRO2 and cerebral blood flow in severe head injury patients and in following subarachnoid hemorrhage. In severe head injury patients, you can also see that CMRO2 and this uncoupling, so that there is increase in the flow, increase in the metabolism requirement. There is no change in the flow. And this is a classical one of the studies which showed that the first 24 hours following head injury, there is a reduction in the cerebral blood flow, and the next 24 to 72 hours, there is an increase in the cerebral blood flow, that is relative hyperemia against a reduction in CMRO2. This is one of the reasons why we always say in head injury patient, do not hyperventilate or do not cause hypocapnia, and maintain normocapnia in the first 24 hours of following head injury, because they're already ischemic, and if you induce further hypocapnia or further vasoconstriction, there is more damage, and cellular recovery may be impaired. And during the 24 to 72 hours, you can have a controlled hyperventilation, provided you have a cerebral oxygenation monitoring, like with NIRS or SjO2 monitoring. With respect to AVM, we have this is one specific situations where, because AVM there is a low flow and low pressure conducting system, most of the flow happens through the AVM because of low pressure, and the surrounding areas becomes ischemic. Once the AVM is resected, the surrounding areas which is maximally dilated because of ischemia, chronic ischemia, can no more take the sudden increase in the flow. So that's one of the reasons why what we call as normal perfusion pressure breakthrough. Though the blood pressures are normal, still the patients can have cerebral hemorrhage, because these vessels surrounding the AVM are chronically vasodilated, and the loss of autoregulation in these patients, and it takes at least few weeks for these vessels to come back to the autoregulation to get normalized. So in these are the patients where we post-operatively, in these patients, we normally have a low pressure, which we keep the pressures around mean of around 80 to 90 millimeters mercury to ensure that there is no perfusion pressure breakthrough. Coming to the ICP, that finishes about the cerebral metabolic rate and cerebral oxygenation and cerebral blood flow. Coming to the ICP, we know the cranium is a rigid vault and it contains brain parenchyma, which is about 75 to 80%, and and the CSF is about 7 to 10% space is occupies, and then blood is about 78%. Now, the CSF is formed in the choroid plexus. This is the choroid plexus you see in the lateral ventricle. It goes into the third ventricle, and this is basically if you look at the structure inside, this is the choroid plexus capillaries. This is fenestrated, and most of the proteins and solutes, everything enters into the choroid stroma, and from there the CSF endothelium, the macroscopic CSF endothelium has got a tight junction. There it controls the flow of these proteins and ions across into the CSF space. This is one of the reasons why you see the change, the ratio of it's not just an ultrafiltrate of the plasma what you see in the CSF. Now this circulates and then it is absorbed into the arachnoid granulations, which is there, arachnoid granulation, which is there on the superior sagittal sinus, and this is how it looks. Is the projections of the superior sagittal sinus into the subarachnoid space. And the reason why I said that there is not an ultrafiltrate of the plasma, because if you see that there is a significant difference in these values, the osmolality and the sodium and other glucose values. Glucose is almost up to 60% of the normal plasma values, and proteins is about 0.5% of the normal plasma levels. Now, glucose is transported, facilitated transport. It does not an active transport, and it does not go along the gradient. It does not depend on the plasma concentration of glucose unless the glucose level goes beyond 300 milligrams percent. The normal formation of CSF is about 0.4 ml per minute, which means that there is about 600 ml of 600 ml of CSF is formed per day. The normal volume in adult is about 150 ml, which means that 4 times the CSF is replaced per day in a day. Normal pressure is about 4.5 to 15 millimeters of mercury in adults. And this is circulation, how it happens. This is the choroid plexus in the lateral ventricle, third ventricle, fourth ventricle, and then foramen magnum and meningeal comes into the subarachnoid space, and you have a basal cisterns, interpreting class cisterns, and from there it moves along the subarachnoid space and towards this is a superior sagittal sinus, wherein the arachnoid, along the arachnoid granulation, it gets absorbed into the venous system. Now, the flow is regulated based on the formation and absorption. Usually the formation absorption is equilibrated so that the ICP is maintained constant, and the absorption is very low or insignificant up to pressure of about 7 millimeters of mercury, 7 centimeters of water, or 4 millimeters of mercury of intracranial pressure. As the pressure increases, there is slight increase in the absorption, and then once it reaches equilibrium, the pressure stabilizes there. Now, what happens when there is a intracranial mass in the intracranial mass? As the volume increases, there is increase in the pressure and there is increase in the absorption. As the absorption increases, there is the intracranial volume reduces, the pressure reduces. As the pressure reduces, the absorption starts coming down and reaches an equilibrium wherein the formation and absorption equilibrates, and that's how they're trying to bring down the ICP and the initial phase of increase in the intracranial volume. As the intracranial volume reduces, what normally sometimes we see as a CSF leak happens of following subarachnoid block, or what we call as a dural puncture. And as the CSF reduces, there is reduction in the absorption and reset at this point. And as slowly as the absorption reduces, it reaches the CSF volume slightly increases and reaches equilibrium at this point, wherein formation and absorption are equilibrated. And no ICP discussion is complete without mentioning about the Monroe-Kelly doctrine. This is Monroe Scottish physician. They describe that whenever there is increase in one of the volumes of one of the in the compartment, either brain, CSF, or blood volume, there is a compensation by other two systems. So whenever the flow, whenever the the blood volume increases, like let's say increase in the blood flow, the CSF is the first thing to compensate. Whenever there is an increase in the, there's a mass in the parenchyma, the CSF and blood both try to compensate for the increase in the ICP and thereby try to reduce the ICP or keep the ICP under control. However, this compensation does exhaust after a particular limit, and you see what we call as end stage of compensatory mechanism, and herniation syndrome can set in. These are the pressure volume responses. These volume pressure response, what is being defined as the change in the pressure with either injection of 1 ml of saline or withdrawal of CSF of 1 ml or 1 second. This is routinely not practiced because of various issues with injection of a saline can suddenly increase if the compliance is reduced, or withdrawal can cause various issues, which and also chances of infection. However, this has been defined with the use of experimental animals. The pressure volume index is another index where it quantifies the relationship between compliance and elastance, and this is taken as a change in the volume to logarithmic change in the pressure, where is tenfold increase in the ICP is taken as at which point the volume is taken as that volume where it increases the logarithmic change. Now 22 to 30 ml is normal, but however these things are not routinely practiced. Now we have invasive the ICP monitoring, wherein we can directly measure this the ICP. This is the pressure volume curve, what we normally see. This is a normal ICP. And as in the initial phase where the compensation is happening, there is not much change in the pressure as the volume increases. Now, when it reaches the critical point, the stroke of the curve, you see a small change in the volume or unit change in the volume cause significant change in the pressures. Similarly, as it goes to the upper or steep portion of the curve, the same change causes further significant increase in the pressures. Now, assume that all our patients with tumors or patients with head injury, or though the patients are in this portion of the curve, we can see here this portion of the curve, though the patients are fully aware, conscious, though the patients coming for tumor surgery, we assume that these patients are this portion of the curve. So why we keep telling about use of drugs wherein you don't increase the hemodynamic responses or upturn the hemodynamic responses, because there is the autoregulation may be impaired, and whenever there is a sudden increase in the pressures, there can be sudden increase in the cerebral blood flow and cerebral blood volume, which can push the patient from this point to this point, which means that there is significant increase in the ICP. So we need to bring the patient from this part of the curve down towards the mid portion of the curve, wherein with various drugs or induction agents like thiopentone or propofol, and ensure that your hemodynamic responses are kept to a minimal, so that you don't push the patient to the steep portion of the curve. This is what I was trying to explain. This is the critical point, and you can see there is the first thing happening to is the CSF in the venous outflow increases, and whenever there is a mass or edema in the brain, as the compensation fails, there is significant increase in the edema, and it reaches the steep portion of the curve. And to come to the normal ICP waveform, you see we have it's something similar to what we see in the arterial waveforms, and we have a P1, which is the percussion wave, which is the arterial pulsations of the choroid plexus, and we have the tidal wave, which tells about the compliance of the brain or the intracranial compartment, and we have the dicrotic wave, which is the closure of the aortic valve. Now, Lundberg described three waveforms: the A waves, B waves, and C waves. We take A waves as pathological waves, which means that the A waves are described as more than 40 millimeters of mercury of ICP for more than 20 minutes of more than 30 minutes of duration, which is called as a plateau waves. Now, whenever there is repeated appearance of the plateau waves during the monitoring, that means these patients have a poor prognosis. And this can be seen in the waveforms when you're monitoring, wherein the P waves or the compliance reduces, thereby when you have a plateau waves, and thereby it stays about the patient is decompensating. B waves, it's seen up to 0.52 waves and associated unstable IC, which means that it is a precursor of the appearance of the plateau waves. The importance of Lundberg C waves is still not being clear. This is very important, wherein we see that this is a Cushing triad. We always look for this in case the bradycardia is the earliest signs of the patients decompensating with the raised ICP, a sudden increase in the ICP. Hypertension is a compensation to maintain the cerebral perfusion pressures when there is increase in the ICP, and respiratory disturbance you see because of herniation. And this is what we call as herniation syndromes. And we should know about this because various herniation results in various symptoms or signs what we try to pick up during in the clinical practice. That this is uncle herniation. This is the most commonest, and this is what the earliest sign of herniation or raised ICP is because of uncle herniation, wherein you see the pupillary asymmetry. And this is what we call central herniation. And so the subfalcian herniation, you see when there's a large tumor in the frontal lobe and there's a subfalcian, and that's why I said that during subfalcian herniation you see the weakness of the lower limbs. So whenever the patients have a large tumor and there's developed with weakness of the lower limb, that means there's a first subfalcian herniation because the anterior cerebral artery is involved. And transcalvarial, because whenever there is a craniotomy is being done and there is increase in the edema, which normally do for decompensated craniotomy for the raised ICP, and whenever there is done, there is herniation of this cranial content, which is necessary for allow it to expand to that craniotomy defect and prevents central herniation, which can result in various cardiovascular and respiratory disturbances. This is a CT scan. This is a subfalcian herniation, and this is what we call transtentorial herniation. You can see the brainstem, everything is being pushed. And this is a transcalvarial herniation, when we see the hematoma and decompression being done, and the edema has been significantly onto the defect site, and you see there is no midline shift. And this is the central herniation, and this is the foramen magnum, and this way you see all the respiratory disturbances and bradycardia and also cardiovascular collapse. Monitoring techniques involves intraventricular catheter monitoring, parenchymal catheter, and tympanic membrane. The most commonly bedside is done in the TCD. One word on parenchymal catheter, because based on parenchymal catheters or intraventricular catheters, intraventricular catheters are more advantageous because we can withdraw CSF whenever there is increase in the ICP, and we can also inject certain medications in case the patient has got ventriculitis or infection, whereas that is not possible with the parenchymal catheter. Finally, coming to blood-brain barrier and cerebral edema, this is extremely important for our day-to-day management of these patients with cerebral edema or patients with raised ICP. Now, blood-brain barrier is brain capillaries, like any of the peripheral catheters, peripheral capillaries. Its main role maintaining the brain homeostasis and protect the integrity of function and from the toxic metabolites. Now, what is important? The difference. What is important of this is, if you look at the peripheral capillaries, there is the junction between the endothelial cells is loose, and then the water and electrolytes can freely diffuse across. However, this is not possible in the cerebral capillaries, wherein they have a tight junction between the endothelial cells, and only the water molecules can pass across, and no other electrolytes or substances can pass through. However, glucose just pass through by facilitated transport, and then it is transport through the active mechanisms. Now, this diffusion happens. Water diffuses purely based on the osmolality gradient across between the blood, intravascular, and then the extravascular or interstitial tissues. Now, importance of this is, if you look at this, the open circles are the water molecules which is freely moves in the intact blood-brain barrier, whereas in a breached blood-brain barrier, you see other molecules, the small molecules also move across. Now, why are we we need to know about this compared to the peripheral capillaries? Compared to peripheral capillaries, we have the tight junctions, and what actually determines the flow of water across movement of these water molecules is your osmolality. The lower the osmolality in the intravascular compartment, there is increase in the water goes along the osmolality gradient. There is the water tries to equilibrate, the osmolality tries to equilibrate, so the water moves out of the intravascular compartment into the interstitial compartment, which will result in cerebral edema. So as in the intraoperative period, in the neurosurgical patients, we do not use hypotonic solutions like lactated ringers, and we only stick to isotonic solutions like 0.9%, which is popular, and also our balanced salt solutions. Hypertonic solutions has a reverse effect. When there is cerebral edema, we tend to use hypertonic solutions because of the gradient, osmolality gradient. The water tends to move into the intravascular compartment and thereby causes reduction in the edema. The various edema which has been explained, vasogenic we see in the head injury patients, ischemic in the cellular failure, which results in cellular failure because of the ischemia resulting from hypotension or because of stroke. In osmotic, just now I told you about how osmolality affects the movement of the water molecules from the intravascular to the extravascular compartment, the interstitial compartment, causing more edema. Cytotoxic, basically the toxic materials. And hydrocephalic, when there is an obstruction to a CSF outflow tract, that can cause periventricular edema. And venous obstruction, which is extremely important because it has capacitance vessels, and obstruction to the venous outflow can significantly result in cerebral edema and can also cause bleeding, which is detrimental in venous, they call the venous thrombosis. And effect of saline and mannitol and hypertonic solutions, mannitol and hypertonic saline on osmolality and on the intracranial pressures. Now, there is significant increase in the osmolality, and because of increase in the osmolality, the water moves out from the extravascular compartment, interstitial compartment, into the intravascular compartment, thereby reducing the edema, which results in the decrease in the intracranial pressure. And it usually stays for about 1 to 2 hours, and then again normalizes. So this is not seen with the saline, which actually increases because it can cause increase in the volume. To summarize, I hope I have touched upon everything and try to give some clinical inputs into that. The various factors actually determine the regulation of cerebral blood flow. What is important is the understanding the autoregulation in these patients. These neurosurgical patients or neurological patients can have affect the cerebral blood flow because of autoregulation can get affected. And it is not necessarily that only neurosurgical patients with tumors have impaired autoregulation. Even patients with stroke, with patients with meningitis or meningeal infections, patients with seizures, all these can affect your cerebral blood flow because of impaired autoregulation, and the mechanisms can fail. And use of inhalation agents, isoflurane is most appropriate. However, seroflurane and desflurane has been shown to be equally effective and has got some protective effect. Of course, xenon has some protective effect, but still it's been in the experimental stages, not being used clinically. And ICP is raised in various situations, most commonly in head injury patients, and also in patients with following SAH, and patients with any of like stroke or cerebral edema. So choice of fluids has to be isotonic and hypotonic solutions in patients with cerebral edema. And the hypotonic solution like lactated ringers, 5% dextrose, is not used in neurosurgical or neurological patients. Thank you.
Thank you, sir, for this extremely informative session.